I'm the Director of Strategy at California Institute for Behavioral Health Solutions. At CIBHS, we recognize two public health crises that are linked by systemic racism. Systemic and structural racism enables police brutality against African Americans and other communities of color. It's also responsible for the disproportionate COVID-19 infections and deaths among African Americans and other racial and ethnic communities. These two interlinked public health crises are social determinants of health that lead to higher incidence of hypervigilance, trauma, anxiety, and depression in communities of color. Given the fact that telehealth has become a core mechanism of providing behavioral health services, there's increased need for behavioral health providers to have the skills to offer excellent care via behavioral telehealth, to increase their awareness of behavioral health disparities resulting from racism, and to learn strategies to eliminate these disparities. For this reason, we've updated our webinar series topics to help you support your clients through these public health crises. It's part of our mission at CIBHS to assist providers to further health equity through your own practices and behaviors. On July 8th, we're going to offer a webinar that will provide tools and strategies to address implicit bias, which undermines effective behavioral telehealth. On July 15th, we'll be sponsoring a panel of behavioral health providers who are offering telehealth in communities of color, hoping to learn more about their strategies and their innovations. If you look at the chat, you'll see that there's a link, and you can visit that link if you would like to register for these two webinars. Now I'd like to introduce today's presenter, KRISTIN Dempsey, who's an LMFT, LPCC, and EDD. KRISTIN is a licensed marriage and family therapist. She's provided psychotherapy in the Bay Area for almost 25 years in public nonprofits and county mental health settings, schools, and medical clinics. Her current psychotherapy practice is located in San Francisco and Burlingame. In addition to clinical work, KRISTIN trains providers in a number of evidence-based and promising practices. She's a member of the Motivational Interviewing network of trainers and has experience teaching and training cognitive behavioral therapy for psychosis, and dialectical behavior therapy. She's a master trainer for applied suicide interventions and has been trained in the neurosequential model of therapeutics to assess trauma impacts in youth and adults. KRISTIN also provides additional programmatic consultation regarding behavioral health system redesign and implementation of evidence-based practices. KRISTIN is engaged in behavioral health workforce development, research, and organizational change projects. She's especially interested in investigating and promoting best practices to recruit and retain underrepresented clinicians in the mental health and substance abuse treatment fields. And with that, I'm going to go ahead and turn this presentation over to KRISTIN.
All right, thank you. Just sharing my webcam here. Good morning, everyone. Thank you for being here today. Yeah, thank you for the introduction. I really appreciate that. I always am very excited to be able to work with folks at CIBHS, and I appreciate being back. 13, 14 weeks ago, when we found ourselves working on screens, I really thought of CIBHS fondly in that all my work, as many of you are experiencing, all of a sudden went on screen, including my psychotherapy practice, my teaching, everything. And having done a number of webinars for this organization, I really appreciated having the skills of doing webinars, because all of a sudden, overnight, I immediately had to do that. So I very much appreciate this. And I'm also very excited to talk about suicide and suicide intervention. It's such an important piece of what we're working with right now. And be curious in our question and answer time, as we talk about just those last couple of months, what people have been experiencing. I always have like a lot of passion for this work, and feel very hopeful around doing interventions to support people. And I have to say, in the last couple of months, just the level of stress and despair has just been overwhelming for all of us. I mean, as practitioners, as well as with my clients. And there's skills and approaches and things I'll be talking about today that I have used in the last couple of months that with people I never thought I'd be necessarily using these interventions with, because we're definitely all in this, you know, that the pandemic, the racism pandemic, the way the pandemic has really shown up in various communities really differently, and with, you know, including all these various health disparities, economic crises. on top of places that we're already challenged, like with, say, like the opioid epidemic, et cetera. Right now, there's no better time to really be thinking about our suicide intervention skills. So to get this started today, I have this beautiful slide in front of you, and there's a reason I have this beautiful slide. I like to think about the suicide intervention work that I do as really important work and promising work and powerful work, and just kind of the reason I'm in this field in a lot of ways, right? To keep people alive and to help people stay alive long enough to be able to develop, lives that are worth living and lives that are abundant. And so when I think about this, I've often had people ask me, I've run into people various times and they ask what I do or what I've been doing that day. And I may have said, well, I've been doing some suicide intervention work. Because of the stigma and the baggage that's often kind of associated with suicide in our community, I'll often get responses like, oh my God, I'm sorry to hear that, or that must be so intense. And I'll often say, no, quite opposite. Today, so far, we have like over 1,600 people on this webinar. And if any of you kind of go back to your workplaces or in your families and are able to use some of these interventions to help save a life, to me, that's like beautiful work. That's really kind of beautiful soul work. And so that's why I start with this beautiful slide, because it reminds me of the importance of the work and kind of the beauty of this work. And that's just kind of how I'd like to set the attitude and intention for the day. Let me just also say, before we go to our next slide and get started, there's often in these presentations a place to think about, well, what is suicide like and how much is it, and kind of some data and statistical slides. I'm not spending a lot of time there today because we know we got a problem, right? We know we got a problem out there, and it's only getting worse with the stress that we have. But just to give you some context, suicide right now, and these are according to stats from 2018, and it takes a couple of years to get statistics because basically people collect the statistics, need to kind of sort them out. Like, what kinds of deaths do we have in our communities that could be suicide? Not everyone leaves a note. There's a lot of stigma around suicide, so it's not always really clear. So this data is even a couple of years old, and if we got something from the last year, last couple of months, it might look differently. But at this point, it's the 10th cause of death in the United States. If you look at young adults, people in college, people around college age, even if they're not in college, it's somewhere like between the 2nd and 3rd cause of death after accidents. And for young adults, it moves 2nd to 3rd cause of death depending on whether they're in college. It's often the 2nd cause of death, with homicide being the 3rd. Outside of college, homicide is the 2nd and suicide is the 3rd. So if you're working with young adults, really important that you're here today. We expect that there's about over 48,000 deaths by suicide in 2018. But again, those are just those that were completed. Please note, I use the word completed and not successful. That's a really important distinction that we make in the suicidology field about there's nothing successful about a suicide, right? We're really trying to be very thoughtful about how we frame this. And that there's probably about 1.4 million attempts, right? So people are doing things that we know are risky, intentional in some way, maybe intentional, we don't know, but there's a lot of people in distress that will benefit from these conversations that we're about to have. And that if you think about just even from the economic perspective, in 2015, suicide and self-injury cost the US $69 billion. So if we're working ahead, not only are we helping to reduce costs in terms of despair, but we're actually helping to reduce financial costs and healthcare costs. So those talking points being maybe important if you're talking policy and planning, right? So I just want to set the frame for this. Also today, we're talking more about, suicide planning is an important piece, right? And like suicide prevention, how to help with prevention plans. And I do have some information on, for sure, we have to think about, before we finish intervening with someone who may have a suicide concern or concerns around suicide. We want to make sure we have a safety plan. But I'm actually spending more time today talking about the relationship that occurs even before the actual plan. You're going to hear me talk a lot about us being the medicine that people need. And I was looking over my slides, and I probably put that in there a little too much. even took some out on my slides I have in front of me, so you may have on your slide set a lot of that. But the importance of a relationship is so critical in terms of prevention and intervention that I'll be referring to that a lot, because a plan a lot of times can be put out there, but without a relation sometimes behind it, it may not really be that effective. So that's where we're going to start. Next slide, please. Okay, I always kind of think about this and this idea of, what do? You get a call or message from a person, especially now when we're all in these screens, and someone says something like, I'm done, I'm so tired of living this way, nothing is worth it. And I'm curious, when you just get that kind of message, right, and what all that means, what are you feeling and how do you respond? How do you respond to that? And please, I have a lot of different ways of trying to engage some interaction here, although I know on this box. Please put some of your thoughts in the question field, if you will, and I'll have Jennifer let me know what some of your responses are. So think about that for a minute. Even like right now, what are you feeling just with that kind of response, and what do you say?
So I'm beginning to get some responses now, KRISTIN.
Great.
For some folks, they feel really concerned. For others, they really want to be able to start with empathy.
Mm-hmm.
The third person is really wondering, what took the person over their limit of tolerance?
Yeah, so there's
a lot of feelings of worry, feeling terrified, scared and sad.
Yeah. And thank you for that. Thank you. And those are all, of course, feelings that we're really uncomfortable with. None of us want to feel worried, concerned, or sad. And let me just put out, first of all, that when we're feeling that way, clearly we want to not feel that way. We want to be effective and to intervene, right? And that's part of what you'll receive today. But also, let me just kind of put that out here too, is that there's a reason you're feeling worried and concerned and sad. And that reason, especially for people in the helping profession, typically it's because you care about people and you want to be effective and you want to be there and you want to have a successful intervention. And I just like to start with that intention, if you will, of, when we come to that place of being great discomfort, what's behind that, what's underneath that, and to drive kind of your own intention and your own desire to be effective. That's an important piece. That's an important way of maybe even kind of propelling you forward during a really difficult situation, just knowing like that's where that's coming from. And then what do you say? So some people you had some questions here about, well, I just want to know kind of what's going on for them. Whatever I say, I want to be empathic. Maybe then that's a response of like, here you're just feeling so frustrated or overwhelmed right now. I think many of us kind of come to this question really worried about, I don't know what to say. I'm afraid I would freeze up. And I think, especially when presented with this slide, the initial response might be, I don't know. But the reality is, on the phone, you'd probably say something. And I'd like to be able just to start with that today, just as we get warmed up and think about this, is that saying something, even if it's not perfect, it's actually perfect enough. What you're trying to do when you first meet with someone and someone calls up is you're just trying to engage. And just being responsive, just picking up the phone is such a powerful act. Again, very simplistic, but I just wanted to really acknowledge that the most important thing you do is engage, and really whatever you do in a lot of ways is really quite perfect. Next slide. So this idea then of the quite perfect, I mean, obviously I'm sure there's some things that someone could say that could be completely inappropriate, but I'm trusting from this place of just being concerned and having some sense of wanting to engage, that what you're doing just by responding is you're helping to address on some level someone's feelings of aloneness, isolation, hopelessness, and pain. That's why there's this connection. Now, we have a different situation here. You're not necessarily working on, say, a hotline or some sort of crisis line. I'm coming from this place of you're actually setting up appointments with someone. So you may have this come up, even just in the conversation, regular conversation, where all of a sudden people are starting to really get into it and they're starting to share some of these feelings. And even if it's someone you've been working with for quite some time, to be able to respond with that kind of concern and engage and be willing to have a conversation about suicide and suicidality is such an important first connection. And even if you have someone who's really despondent, I don't feel like talking about it right now, I don't want to be here, they're still talking to you about it. There's still kind of a call for help there. And I think this is kind of where my thesis is about us being the medicine. The most important thing we do when we get these messages, especially these messages of distress, is to slow it down. Again, there's an impulse to want to respond immediately, get to a plan, get someone safe. Totally makes sense, right? We're worried about them. We're worried about ourselves, in terms of responsibility, legal and ethical issues. We're worried about compliance. So there's a lot of pieces here. And yet at that moment, unless someone has a weapon right there they're going to potentially use for themselves, and that's kind of a whole other piece we'll talk about in a minute about directive versus kind of guiding actions. For most of the folks we work with, we can slow it down. We can slow it down and listen, be curious, be open, be kind of the hope that people often don't have when they get to this position. So we're giving them exactly what they need when they need it, which is human connection. Next slide, please. Okay, so I bring this up, this idea of first things first, which is we're working remotely, and we're working on phones, we're working on screens. This is kind of a challenging position, right? It's already challenging enough to be working with individuals who might be struggling and might be, not with us, but I don't know where this person is. So this is for this reason, for suicidality or crisis in general. We want to know where people are located, right? Like, where are they when they're calling us? We should always have a crisis. This is kind of like a basic thing now in telemedicine. You always want to know, like, where people are calling from and where they're located, right? Just like what city they're in, clearly, because you want to be able to think about, well, wait, I'm in San Francisco, they're in Alameda. If they're suicidal and if there's something at the end of the call, I need more assistance. They're not able to engage with me around a plan. I need to be more directive. Who do I call in Alameda County? It's maybe different, obviously, from who I call in San Francisco County. So the fact that we're working remotely, that brings up an issue. And I'm working right now with students who are working on a support line, video work as well, and I'm helping to put together some of these resources. Wait, they're not seeing people necessarily from the town that the university is located in. They're seeing people from all over the Bay Area. So it's being able to research and know, who do I have in different communities. And again, you might have that fairly limited right now if you're working for an agency that still only sees people in your community, but you still want to know and know where their physical address is. This also becomes an issue because so many of our clients are seeing us in cars. I have people who see me in cars. They have no other place to go. Bathrooms, laundry rooms, garages, but if they're in their car, like, where's that car parked? And being able to bring it up in a way of like, hey, I'm here in my office in San Francisco, and it's kind of foggy, sunny, you can cut the skylight. Where are you right now? It's like, oh, okay, you at home and you're at the address, just bring it casually. Oh, you're in your car. Well, where are you in your car? Are you at home at your address? So just being curious even before we kind of get started. It can be transparent about that. Like, hey, I just check where everybody is whenever I start a session, just in case anything comes up and we need more support. What is their phone number? That's important too, because even if I'm working online with them, it's just not good to have internet go out. Everybody's on the internet now. And then if we're in a kind of a deep conversation, all of a sudden everything falls apart. I want to be able to call them and find out where they're at. People get disconnected all the time. And if on video, can we see the person's face? And it's really nice to be able to see people's faces because we can see if they're in distress. That said, I mean, we've had over 50 years of suicide prevention hotlines. People have been doing great work for suicide prevention and intervention on phones for years. We have some great success right now with even chat lines. So we know this can be done. But if we can, and it's great to be able to see people, especially because for so many reasons, there can be different levels of messaging. We know the power of nonverbal versus verbal and how nonverbal conveys so much more. And I also want to say too, internet, of course, is also an issue of privilege as well, right? I mean, who has internet? Who has good internet? Who has consistent internet? Certainly an issue around economics. And I have a number of folks I see who they basically have their phone and they're fortunate to have their phone. And if they have a smartphone, increasingly more people have smartphones. A lot of our formats, I use Zoom, people use different formats, work really nicely on the phone. Again, I'm sure there can be some differences in terms of platforms, but I've had some great luck with Zoom on smartphones, actually, especially for those people in the cars. Next slide. Okay, and I'm going to start here too, just with this idea of really what are some basic suicide intervention needs. So I am trying to be very thoughtful and careful not to step on any proprietary kind of suicide intervention model. There's a lot of different evidence-based practices out there that, this is our model of suicide intervention, and I'm trying to be very, I know them, and I'm trying to be very thoughtful about not using all of their terms or, inappropriately, for instance. But I also pulled together a lot of the work I've been doing for the last 10 years or so to figure out, like, what do all these models have in common? What seems to be the common factors, a common evidence base for when you're doing appropriate suicide intervention work? And again, I'm really focusing today on skills, on what do we do, how do we say it. And so I found some, and I also, as I talk today, a couple things I'm going to do. I've got placed a lot of this into a motivational interviewing model. It's kind of what I do. I feel very comfortable with it, but I think suicide intervention, especially that early place where someone's calling, they're really ambivalent, fits really nicely into an MI model. I also have used and pulled stats from a number of public sources. So you don't have to pay money to get access to this. These are things that are, online. I have some online resources, just things you can have access to, right? So I was thinking about that as well. And also there's just some really great resources out there that even beyond today, you can use. Just to give you an example, I'm going to talk a lot about the American Association of Suicidality, and it's a great research organization. And I'm not being paid. I'm not a member of the organization, but if you ever get a chance to go to one of their conferences, they're fantastic. I mean, they do just really wonderful training and the research and putting it into practice. There's just all various aspects. And I was asked once to meet with a family, just kind of concealing some of the identifying issues here, but just basically they lost a child to suicide, and it was really soon. And I mean, just going to talk, even as a therapist, with someone who's had that kind of loss, like the day of, is, it was powerful. And I had to really think of it. And I want to be really well prepared. And I went on their website, and they have all kinds of great, like, post-intervention resources for families, for clinicians who have lost clients to suicidality, and just suicide rather, and just started to print things out and just to have things in resources. Like, this stuff just comes up sometimes, and it's so wonderful to have some very excellent organizations out there that are extremely well resourced. So just a pitch out there for some of these resources I'm going to give you. But a couple of basic things that we're looking at is you really want to know, like, what warning signs are. And I'm going to make a distinction here in a couple minutes between risk factors and warning signs. That's really important. The things that we want to be really attentive to in our assessment. We want to focus specifically and directly on suicide. It's really uncomfortable. I ask specifically about suicide at least a couple times a week right now, at least, because there's just enough warning signs, there's just enough despair, and I just put it right out there. Are you thinking of killing yourself? I get like you're really frustrated and hurt and overwhelmed right now. is thinking about suicide part of what's happening for you? I just tried to be really direct about that. Say more about that in a minute. And then once kind of suicidal ideation has been established, it's okay to slow it down a bit. People are ambivalent often, especially for the fact that they actually have not already died by suicide, but they're talking to you, right? So it's an opportunity. So let's just kind of slow it down and use kind of our active listening skills and really try to be in connection with them. This comes into my "you are the medicine" theme. This is exactly what they need. They need human contact. It sounds weird because we're in these boxes, but even the screen contact is powerful. It's really powerful. And we want to help people work with their ambivalence, at least give them enough reason to basically contract, to do some safety planning, trying to move them to that side of their ambivalence to where I'm willing to do some safety planning in the moment. And then we want to basically be able to establish a safety plan. How do we deactivate any self-harm plan they have? Where do we promote their protective factors? I'll talk about that in a minute. And how do we link to resources? So these are kind of the common factors, if you will. Next slide, please. And so why motivational interviewing? First of all, is I think a lot of people on this webinar have probably been exposed to motivational interviewing at some point. And motivational interviewing is not a theoretical orientation. It's just really kind of strategically talking about change, having conversations about change. And well, what's the status quo and what's change in suicide, right? So the status quo is often, that I'm in a lot of pain. I'm in so much pain. I've had so much loss. I want to die. That's what people are coming to us with. And then what do we want for change? Well, would love it for them to be right straight out, I want to live. But if we can encourage people to at least be, I'm willing to make a plan to consider my next steps in not dying. I'm willing to have a plan to think about, living, at least for a bit to kind of figure out maybe my next steps. That's wonderful. And so some of the process of MI, I'm going to talk about in a minute, how we can start to engage in that process in order to have conversations about change, with the change being moving from thinking about suicide to thinking about staying safe. And in the middle of this, the idea of slowing it down, the reflective listening, the being curious, think of that as like the bridge between this status quo of I want to die to I'm willing to talk about safety planning. And again, it's so tempting to come in and want to be like, oh my goodness, someone's suicidal. Here, let's make a plan. You don't want to do that. Well, yeah, actually, I do want to do that. So how do we have a conversation with them about what's going on for you? Let's explore this a bit, because it's in that conversation that we really get a chance to create the motivational energy to be like, well, okay, you know what, I'll call my sister, or whatever it might be. These little pieces that we're trying to put together to help somebody get safe and start to contemplate and really think about acting on staying safe. So for the question box, sometimes we ask these things in like training, even like I know in suicide line trainings too, throwing out things that people might say, because rarely is somebody's ambivalence so obvious. People can still come in with just this, I just want to die, or they can just feel like, suicide just really what I want to do. There's just no way out. Those kinds of things that feel very stuck. And remember this idea that when someone's just feeling that way, to be able just to be curious about that feeling. It sounds like things are so hard right now. Like that starts to, when you become evocative and help them explore, it starts to shake up some of that stuckness. So for the question box, I have this idea of, today I just want to die. In the context of a teletherapy session, what about that is an example of ambivalence? What part of that statement is potentially ambivalent? So I'm curious what people come up with for that. So I'll give you a second to do that. This idea of today, I just want to die. Any questions coming in so far? Any answers?
Yeah, there
Yay.
are, hang on one second.
I know there's probably a lot of people on the call, so I appreciate that. That's great. That means people are thinking about this.
I think that they're really kind of seeing the ambivalence in terms of people are talking about the fact that they want to die, and yet they are actually still in session. I think that another person really feels like saying I just want to die is speaking to a feeling or a thought rather than an intent and a certainty, such as I'm going to die by, and then talking about how they plan to do that.
Yeah. Great.
And yeah. And just, I think, really kind of thinking through, they might be seeking alternatives, but not knowing where or how. So, really that's,
nice.
They're thinking about it, but not necessarily, certain.
Yeah, right. And so how to respond to this? So there's a lot of different ways of responding. And I like what people are thinking of is just, first of all, take a deep breath and just being like, right now, today it's just feeling like so hard. And again, just being so curious. And I'm going to talk about more of the technique here in a minute. And also for this particular slide, this idea of like today, it's like, well, you just want to do this, but maybe there's other days when you haven't, maybe that's
right.
part of the ambivalence too, kind of going back between different states, different mind states. Are like right now, it's just things are really hard. Yeah, great. Thank you for that. Okay, I'm going to move on to the next slide. Okay, so this is the processes of motivational interviewing, and I bring this up because this is so helpful to think about in terms of suicidality. So the first thing you want to do is that engaging. So we kind of think of these as a stairs, and if you get Miller and Rolnick's book, they talk about this, and there's a lot of resources out there about motivational interviewing that are pretty easy access if you don't already have them. I'm glad at the end to say more about that. But the first thing we do is these are kind of linear processes, right? We're thinking of you're kind of going up these steps. We can also think of these processes also kind of like a layer cake, and that each of them build on each other. And so if you think of stages of change, and I don't want to get too far afield in this because of time, but basically any of us, for any issue that we have, are in pre-action or we're in action, right? We're pre-action is I'm thinking about it, I'm contemplating, or maybe I'm even before that, I don't even think I have a problem. Then I get to contemplating, and then maybe I'm preparing a bit, and I'm thinking about, well, what I want to maybe do, but I haven't actually done it yet. So cognitively I'm thinking, but I haven't actually done it. And then we get into action. Well, we love folks who come in to us who are talking about suicide to be in action, and to be in action quickly, right? just for our own comfort and for their own wellness. And yet it's like going up these steps is often what we're doing in sessions with people. So thinking of that idea of one of my first slides, when you get that phone call or that first introduction on the Zoom meeting, if you will, someone just saying, I'm had it, I can't do this anymore, it's over. And you start to just reflect or be curious, that's often the engaging piece. And that may take some time. I say take some time, but we're exploring, we're wondering about the warning signs, which I'll talk about in a minute, where we're looking for any particular issues. We're just exploring and helping someone really have words for this. There are a lot of people that just in this engaging place and just having reflective listening, that they won't really be feeling actively suicidal as a result. It's just making the human connection so powerful. But at some point, we always need to focus in some ways by actually asking about suicide. And I'll talk about that in a couple of slides, which is, this is what we're focused on right now. We're going to talk and make sure we know this, because it can be easy to say, well, no, it's, things aren't really that bad if we don't really ask about it, or we can be talking around it. And this is important because of safety issues. We have to make sure that we're talking about this. And sometimes you will have people who really are ambivalent. They're talking, but they're not necessarily going to bring it up and deal with it unless kind of prompted. Once we know that someone is feeling suicidal, then we can be more evocative about, help me understand what's going on, help me understand about your losses, your pain, the meaning of this. And we're listening really carefully for what we call an MI change talk, right? So we're looking to see what might help somebody stay alive, so we can start to move them into safety planning. We can start to summarize and be curious about some of the reasons for change, in this case, for staying alive. So maybe as they're talking about things like they value, kids, family, meaning in their life, spirituality, taking care of their cat. All of these things can be important that we can summarize and bring into our planning stage. I'm going to break these down in a minute. So I'm going to move on from this slide and give you more concrete examples of all of this in a minute. So next slide. So if any of you know about motivational interviewing, again, you may know about some of these interventions. You may have heard of OARS, OARS. Can't get anywhere without your OARS, open-ended questions, affirmations, reflections, or summaries. Some of us are using this idea, the new acronym of AROSE, which I like, just because I like roses. But I like it too because it includes this newer intervention that we're using a lot in MI about how to give information and advice. So in the more recent editions of motivational interviewing, we're looking at how do you engage somebody in information and advice giving in ways that they'll actually take it and not reject it. And that's important because especially if someone is suicidal in this case, if I just tell someone what to do, you can start to get into some yeah-butting. Yeah, but this is so bad. Yeah, but no, I just can't do that. No, no one would understand. So you start to get into this. So this elicit, provide, elicit, which is the last piece here. We can also think of ask, offer, ask, which is basically we ask permission. Have some thoughts about all this that you're going through right now. Would you like some information? Would you like some options of various next steps you might be able to take? We offer it. Maybe we're offering people they can connect with, connecting with someone in their resource, taking a step back and calling someone, whatever it might be. It's great to offer a few things so people can choose from them, because people are more likely to choose than to do one thing that they're told. Like we tend to respond to that better. And then you ask again about anything here that you'd like to start with. Any of this makes sense? Of all the options we're just talking about, is there anything that you would be willing to do? So that becomes very important as we talk about the safety planning in a minute, right? Because we want to have these conversations, but when someone, especially I think sometimes when someone's suicidal, to be told what to do can feel very disempowering. And then that can be just, no, I'm going to resist this a little bit because I need to have some control. So this is a way of working with some of that. These other interventions you might be more familiar with. Affirming is like noticing things that people are doing, like behaviorally, that we can point out and magnify for them. So I might affirm, like, it takes a lot of courage to talk about how you're feeling right now. I know you have a lot on your plate, and even though you're feeling a lot of despair, you've also shown like a lot of strength in ways that you've gotten through some really challenging times. So what we're trying to do is we're trying to help people notice their own strengths, because when we do, they're more likely to leverage those for change. That increases motivation because it increases people's sense of self-efficacy, and it lessens one's feeling of I'm damaged. So that's why that's important. Reflections is basically your active listening. Some of you may be familiar with that, but it's being able to notice and reflect back what it is the mirroring, if you will, what somebody's saying. And seeing that many of you were talking about that earlier when someone calls up and it's just like, I don't know what to do, I'm done with this, to immediately go through just reflecting back their experiences, the thoughts that they're having, the meaning of those thoughts, their feelings, that engages people in a way where it's like, you really hear me, you're listening. And when someone's suicidal, again, that's some of the most important medicine. Open-ended questions are very important now. Want to be careful about doing too many, like especially closed questions, or even just too many questions in general when someone's suicidal. Especially if someone feels over-interrogated, they can become very self-conscious. You can have people feel kind of scared or unheard of, or they get really worried right away they're going to be hospitalized. And if they've been down that path before, they might really clam up or leave or shut down. And we don't want that to happen. We want to have people to be engaged. Even if it does turn out that they can't engage in a safety plan and we're really worried about them, and we do need, in fact, to have someone else come and do an assessment and maybe do something more directive in terms of intervention, we don't want to go there too soon. We want to slow it down a bit and see where people are at and help them feel safe. Summaries are really helpful, just so there's a sense of I'm following you, I'm collecting your information. When any of us are feeling a lot of despair, especially suicidality, part of what's going on is I am so overwhelmed. I just can't think about living. I mean, I don't know what to do with all that I have going on. I think we have a lot of that happening right now with the pandemic too. If you're unemployed, kids are all at home, you're not sure we're gonna be able to go out, worried about being sick. I mean, there's so many things that people are so overwhelmed. To be able to summarize and help folks focus can be really powerful, especially because it may mean that you're hearing me, but also to summarize some of the reasons for change can also be really powerful. You've really heard me because you're able to summarize some of the reasons why maybe I would want to live another day, right? And that is very compelling. Next slide, please. Okay, so a couple things I want to kind of get into then is this idea of when we're engaging the importance of, we call those first planks before we get to focus on suicide, this idea of like who's potentially suicidal. How do you know? Do people come to session actually talking about, well, I want to kill myself? And typically not. Some people do, but but not always. And we have to be able to be really attuned to warning signs. Again, because of time, I'm not going to go through each one of these risk factors per se, but there's a point I want to make about risk factors, which is clearly, we kind of know from the research that some people, when they have some of these things on board, they may be more likely to potentially think of suicide as an option. And I'll just say, point some of these out and give you some ideas around that, why that's the case. And so this is really important to know about for prevention work or for your assessment, right? You get to know somebody and you're kind of looking at this and okay, there's a family history of suicide. Why is that? Potentially some genetic pieces, but one thing that occurs is that there's a certain amount of familiarity. If we've ever tried to do suicide ourselves, or if there's someone in our family who's done it, like there's something that makes suicide it's kind of weird, but maybe a little less scary, a little more familiar, more of an option. So, okay, there's some family history, something to really keep in my mind. That could make someone more vulnerable. Someone's using a lot. I work a lot with using substances. I'm pointing to the first row, last box. Yeah, I want to be really thinking about that because suicide can certainly occur if someone's less inhibited, right? It's like there's less emotional control, less behavioral control if someone's been using. Also, just the nature of substance use and long-term substance use creates a lot of losses and it creates a lot of grief, so people are more vulnerable. Okay, I want to be thinking about that. We know, thinking of the bottom row in the middle there, physical illness. People who've had long chronic illnesses could just be like, I'm in too much pain. I'm not going to get better, right? So you can see how we kind of look at each and every one of these. There's something here that we can see where, yeah, this could really be a risk factor. Absolutely important to know, potentially important to explore at times, for sure. And we can all think of people that we know of, or situations that we've heard of where people have had these risk factors and they were in fact suicidal or had suicidal ideation, or they had died by suicide. But you can probably also think of people who had some of these risk factors and they never did even consider suicide for a minute. I've known many people who have been depressed. Suicide was not part of their thinking. There's students in schools where there may have been local epidemics of suicide. Looking at the second row there at the end, that had not occurred for them. In fact, they may have gotten involved in student groups to do suicide intervention. Right? They were not impacted in that way. Barriers to assessing mental health treatment. Sometimes people have used their own community members, other support, found other ways to seek help. So here's a thing to remember is that risk factors certainly should be explored, but risk factors are not quite the same as warning signs. And one thing sometimes I'll say may seem a bit inappropriate at times, but it's an example of this is you can think of someone who, like, maybe in a divorce situation, and that for them, like, because of what they value, and losing a part of their family, losing a partner, they could be suicidally depressed. And you can have other people get in divorce where they're going to Disneyland, right? And so maybe that's a risk factor, but you have to know individually for that person at that time, how's it showing up for them. So we'll go ahead and move to the next slide. And I think so this slide is like risk factors are not warning signs. So always be curious about risk factors as you explore them. Warning signs might start to appear, and we definitely want to be concerned about those. So I'm going to move to the next slide, and this is from the American Association of Suicidology. Can't talk. And here is something that's important. We'll talk about some of these warning signs in a minute in terms of specific warning signs. But here's another piece we want to think about. Some of the warning signs, like threatening to hurt or kill oneself, wanting to hurt, or looking for ways to kill themselves by seeking access to firearms, talking, writing about death or dying. This is pretty obvious, right? But warning signs are not always communicated directly or outwardly. How might they be communicated in a video or telephone session? Like, how might that start to show up? How might you notice that? I'm curious about what you think, just how you might think about that in terms of some ideas of warning signs or things you'd want to be concerned about. So give folks a second to respond to that. We'll move to our next slide. As people are responding to that, and I'll go back to that, I'll talk about this just in terms of picking up my time a little bit. So other, kind of warning signs that we're thinking about, people talking about, increased substance use. So by the way, there's actually an acronym for this called ISPathWARM that actually goes through all of these, and I'll show it on the next slide here. So if people are actually, in fact, increasing their substance and drug use, you want to be thinking about that. That could be a potential warning sign that someone's in more distress. And also thinking about this in the context of pandemic, it's one thing that we're getting a lot of reports on, that people are using more substances. The boredom, the stress, being at home, it's like substances have a really high reward factor. People will say, like, they not feel like they have a purpose in life. Anxiety, agitation, unable to sleep, or sleeping all the time. Again, we're seeing a lot of sleep disruption. Feeling trapped, like there's no way out. Again, we're in a situation where there isn't a whole lot of control over our current situations. Hopelessness is also often an emotional component of suicidality, of a warning sign that we want to be really careful about, because clearly someone's feeling hopeless. There can be this idea, it fits in with being trapped, like there's nothing I can do, I don't have choices. People are withdrawing from friends, or there's uncontrolled rage or anger, seeking revenge. And sometimes you will also see some of that in terms of what we see suicide homicide patterns sometimes, or even like things like suicide by cop, where there's can be some acting out with others, or aggression in the community, and then but there can be hurting others in addition to killing oneself, or having, like, say, police kill oneself. Acting reckless or engaging in risky activities. Dramatic mood changes, something we need to be watching. And also, of course, we talk about this a lot. It's often one that people think about is when people are giving away possessions, seeking home for their pets, that kind of thing. Or trying to make other plans. Really got to wonder, like, okay, this is a warning sign we're concerned about. So what I'm curious about anything that's been coming up in the chat box or in the question box.
Yeah, there's a lot of feedback coming in. There's a lot of folks that are seeing sleep disruptions, irritability, and rage. There's another person who really feels like it is very difficult to see red flags via telehealth. Their interventions have been further and deeper prompting. They're trying to normalize symptoms that others may be feeling, ask if the client's having similar experiences. So I do think that this issue of trying to do suicide interventions via telehealth is very much a challenge. In terms of other signs that folks are seeing, verbal expressions change. They can become more aggressive or regressive. There's another interesting one. Another concern that came up was that somebody's working with adolescents who is recognizing that they're, that they're really experiencing, their clients are experiencing a lot of talk of suicide online. And her client talked about it very casually. And so this therapist was really concerned about that.
Right. Yeah, absolutely. So again, it's scary, and it's also like a great opportunity to start talking, being really curious about that. And let me see the next slide here, because that could be, that could be some aspect of ideation potentially, or just, if being curious about it, like, let's have a conversation about how that shows up for you and how you're feeling about this as well. Like, and then I'll talk about this in a couple of slides. After we're done exploring warning signs, if there's enough of these going on here, we want to start, asking directly about, do you ever think about dying by suicide yourself? And just because if you start to have the conversation, I guess I just kind of answered my question here for the chat box, but that does, start to set the stage for then asking that really important piece. So think about like the exploring all of these warning signs. You're noticing like these things are out here. How do we explore and just start to create conversation? Think of it as that first plank. You're engaging and being really curious, and you're normalizing. A couple things that happens here just in the relationship is I'm showing that I'm not afraid to talk about this, that people have these thoughts. It's okay for you to talk about it with me right now. And we always have someone who may just really be at risk, and we'll talk about that in the plan. But for a lot of folks, they're pretty eager to have some conversations around this. So in the warning signs I just gave you, there's like an acronym that kind of is associated with them. It's called Is Path Warm? And this also comes from the American Association of Suicidology. And these little signs that people have made, I got this from, I think, the Navy, but there's different signs you can have. And this is a good little assessment tool to have around or be thinking about this. Like, oh, what were the warning signs again? So the idea of ideation, talk about substance abuse, always with substance abuse. Again, I talk about increasing substance abuse. Again, some people, not an issue at all, but we do want to explore that. The idea of I don't have a purpose. Anxiety, people always think about depression in terms of suicide. Actually, people sometimes who have really intense anxiety can sometimes be just as at risk, both with depression and anxiety. And with all of these, really, you can have any level of this and be okay. I mean, I can have mood change, I can be okay. I can be withdrawn, I can be okay. It's pandemic. But what we're looking for any of these warning signs is how much pain is somebody feeling as a result of having this warning sign? Are they experiencing like loss? Like what meaning do they ascribe to any of this? Like I'm having anxiety, and the meaning for me is I'm ruminating, I just can't stand it, I just can't live like this. Whereas other people can have anxiety, it can even be pretty bad, and it's just like, oh, this ejaculate's uncomfortable, but they're not going to that place of I'm in so much pain, I got to stop it. So you can see like along a continuum, all these things could be along a continuum, whether that be being trapped or being hopeless. You can have like mild levels of hopelessness, and they can kind of come and go. I noticed that a lot in the pandemic. Also with withdrawal and anger, that can also there's times when people can be more engaged and more withdrawn, but again, when it gets to be severe and it's really starting to get into people's way, that's when we start getting concerned, and that's when we get to kind of the next step of, okay, exploring this. I need to ask the question. I need to get that focus. And next slide. So moving into focus. So what we're doing now, if I'm getting a few warning signs, getting a really strong sense of like there's a lot of pain, there's a lot of loss, there's a lot of distress, you want to ask directly and clearly about suicide. And I mean, I'm using these terms. Are you thinking of killing yourself? Are you considering taking your life? Really direct, really uncomfortable to ask. And in a lot of training, do like a suicide prevention or intervention training, often there'll be some point of practice where people turn to each other and ask the question just to get practice in asking the question. So it may sound a little odd, but if you're with somebody right now, I encourage you just to try asking or finding words for it. Are you planning to die by suicide? And thinking too, like culturally being really sensitive in terms of age. I think also like linguistics, like in the cultures that you're working with, do people use the term suicide? Not everybody does. Most people can recognize the idea of like taking one's life, killing yourself. I mean, it's, just to make sure you have terms that people relate to, right? Because I can have term that sounds really clinical to a client. It doesn't, they're not connecting to it. And they might say no, not because they're not thinking of it, but just because it doesn't make sense. And then when we kind of answer that, like now we have our focuses agreed upon, now we can start going into the evocation stage, if you will, and be really curious and thinking, let's have a conversation about this, because we know you're ambivalent. I don't necessarily say this to the client. I'm thinking to my head, I know you're ambivalent because you're talking to me. And even if someone's like, I just want to die, and if they're just agitated as heck around it, like there's a lot of life in that kind of presentation. There's a lot of life in sitting in front of me and just struggling and being frustrated. And I'm going to work with that. And then I put this here. Again, might come out, it's quite obvious, but just for people to chat, put in the chat question box, sorry, keep saying chat. Why might it be problematic for us to say something not as direct, like, are you planning to hurt yourself? I'm curious what you come up with as an answer to that. So I'll check on the answer in a second. Next slide. Okay, so again, me going back to my medicine metaphor, but that's the relationship, we can slow it down. Again, you wouldn't slow it down if somebody's like, yeah, I'm suicidal and I have a gun right here, and when we're done, I'm gonna pick it up, I'm gonna kill myself, or someone goes into the video, and I've had someone do this to me in person, so I'm sure it could happen on video, and they take their medications and they go and they chug them down, right? I mean, obviously at that point, there's no slowing it down. There's like calling your local emergency response team. But for the great majority of people, we can slow it down and be this healing medicine that they need. So stopping and checking on the question box. Anything about that last question I had asked?
I'm getting a lot of different questions and feedback coming in. So can you repeat the question?
Yeah, so the question before was like, why is it important to be really directive about asking about suicide, as opposed to, you're not going to hurt yourself, are you? that kind of more vague response.
Yeah, one is that if you don't ask the direct question, it can basically stop the person from really being able to talk about the fact that they do want to kill themselves.
Yeah, exactly.
Somebody said, although I know it's best to talk directly about suicide, I often hesitate due to being concerned that it might upset the client more.
Yeah. So really good. I'm glad you brought that up. And obviously there can be a lot of different ways people can respond, but what we've found and what seems to be a case is, first of all, bringing up suicide does not make somebody suicidal. Like that kind of, sometimes there's people who are worried about, like, if I bring it up, will that cause someone to think about it? Like, and a lot of research around that people don't just all of a sudden think of suicide. Like it's a, or if someone mentions it, like, yeah, I should just do it. Like that doesn't happen. I mean, not saying anybody's saying that, but sometimes that's a concern. And there's also the piece that sometimes we bring up the suicides. A couple things often happens is that, one, it's like it creates a reality of like, I've had this happen a lot. Like, oh wow, am I sounding like that? Like people are feeling really, but they don't quite get it, and this kind of pops them back into like, wow, I'm not, but I might. Is that going? Is that what's going on? Or there's a lot of different ways. Sometimes people will have this response of relief, like, yeah, I didn't want to say it, I couldn't say it, I didn't have the words for it. I mean, now that you're talking about it, you just shown me, KRISTIN, you can handle talking about this. So yeah, let's talk about it. Now, I know what you're saying though about that idea of like just bringing it up can feel really jarring from some people, and so you can kind of walk into it slowly. So when you're in that engaging stage, sometimes I'll summarize before I get there, and it's like, maybe even if I have someone who might be a little bit fragile, off, who isn't when they're thinking of suicide, but I might be thinking of something like, I get like, this is really intense right now. You have a lot going on. You're feeling really hopeless, a lot of loss and a lot of grief. And this might sound like really, heavy to think about. I'm wondering, because I'm hearing this, and I need to know this because care a lot about you. I'm concerned about your safety. But are you thinking of killing yourself? Does that ever come up? And I find sometimes with that slow kind of build up to it, and then putting it out there, like, hey, there's a reason for it. That can help with that. So hopefully that might have answered that a little bit. great questions. I'm going to
Yeah,
move to
these
the
are great.
great. I'm looking forward to them at the end. So we'll see other things that people have. Next slide. Okay, so stop and listen. So with the evocation stage of kind of getting there, but you were trying to do that bridge now between, like, okay, no suicide's issue now. I mean, I have a goal. I'm gonna be, we have a goal. We have an ethical goal. We have, like, engage someone to be safe. At some point, this motivational strategies are out the window if at the end of our talk, like, someone is still, like, planning on hurting themselves. I mean, we do have to be more directive. But before we go there, like, spending time here is really important because many people, many clients can tell you of times, maybe people on this call too, of times when they've mentioned suicide and then someone immediately gets concerned, comes from a good place, and, like, we're gonna call the mobile response team right now and get you into the hospital, or it kind of goes really fast, and then that in of itself can be traumatizing for clients. There can also be this thing of, what I've learned from that? I've learned I'm not going to tell anybody else again, like, when I'm feeling suicidal, because I don't want to spend time in the hospital necessarily. So just thinking about that for a minute and just witnessing and reflecting the pain. Look for the ambivalence. It can be obvious or it can be subtle. So remember, they're talking with you. That alone can show ambivalence. I'm really into the double-sided reflection and motivational interviewing. I mean, just it creates that bridge. Like, you're feeling so hopeless and stuck right now, and you're also saying that you really want to be there for your cat, which and the pets do not think, and pets are really important for change talk. I've had so many people who've had all kinds of things in their life, but I got to get back and feed Fluffy. It's like the one thing sometimes that gets people to a safety plan. Pets are important, so I'm using that as an example. And so that, instead of the idea of, let's do a safety plan because you really can't do this to your kids, right? You can't do, because you have a lot of responsibility. You can't do that. What about your kids? And even though I'm thinking that, I have to be careful not to say that, because that can increase guilt and also can just increase the kind of pushback you get when we move too quickly towards change and someone isn't ready. So this is part of a necessary step often. So again, putting out that idea of just being able to reflect here about that pain, that there's something that was really important that was often lost, that's often being grieved. So we want to reflect the double side of that, right? Like, oh, that was so important to you, and it really hurts to lose that. And notice I say and not but, so I'll link them together. And you really value participating in your community, and you really value being a good parent, and you really value being, the best worker in your field, and so you're kind of putting those things together. Next slide. So moving into planning from change talk. So for a suicidal individual, the status quo is like wanting to kill themselves, or maybe wanting's not quite the right word, but it's that verbalization about killing themselves. So what we're doing is we're trying to listen for any little piece of change talk. And again, if you know MI, you know about darn cat. And darn being the desire, ability, reason, or need to change. Can show up with, like, I really want to be a good parent for my kids, right? I know I could get back in the workforce at some point. It's just so hard right now. You're listening for those little pieces, those little seeds. And the more we're likely to reflect on it, the more we maybe get to this sense of, like, commitment change talk, activations, kind of like, maybe I'm willing, I'll try. Taking steps are little steps around this. And so what we're doing at the evocation stage is we're listening for just, like, any little piece of this change talk that we can then start to build into a summary that will move us into planning stage. So I might be listening to someone's despair, and again, if someone's in despair, think about this. Like, there's something they lost, something that they really hurt. That means they have values. That means the things that I feel hopeless about, and I feel so sad about, and I feel so despondent about, they're important to me. So I feel terrible about losing my job. This wasn't fair. This wasn't right. I'm worried about my family. Now what am I going to do? I just can't be here. Well, what do I know about this person? I know that they want to be there for their family. I know that they need to have a job to feel important. Like, they want to be a part of that. So we get a chance then to be able to really reflect on those important parts that they're showing us, they're telling us in this conversation. So the way we can then link some of this evocative change talk that we've been having is, we've been talking about the grief around losing your job, and I also hear you saying how you want to be present for your kids, and you're willing to talk more about your options with me. And are you willing to talk more about your options with me, given what you want to do next? So I just kind of pull some of that change talk together, and now it makes more sense because I've been talking about it and I've been reflecting on it. If I immediately went to, what about your kids and what about your family, as soon as they told me that they were thinking of suicide, that may have been too soon. So we need to kind of work on this and build this reflection and this attention before we can get to this like bridging types of statements. Next slide. Okay, so presuming that we get to the top plank there, we're getting to planning. In MIs, planning for change. In this case, this is where we get into safety planning. So I gave you a safety planning guide. There's tons of stuff online that you can use and that you can, decide if you like that for your practice, or if you're, many of you, if you're in counties or in community-based organizations, you may have your own safety planning guide for your organization. Please use that. I encourage you to look at things, talk about them in staff meetings, figure out like what works for you given your time. If you're working in a brief setting, you may not, you may have to have things that are pretty quick and efficient. And I will give you these websites at the end of this webinar too, to really explore. So I found this one. This one was, I think, from a college, but I liked it. I really liked it, and I got it from the suicide prevention. It's a resource. SPRC. I'm sorry, I forgot the name of the link. It's a suicide prevention. Basically, it's a clearinghouse for evidence-based practices around suicide prevention intervention, and it's a great resource for just kind of looking through some of these things. So in safety planning, in addition to being able to help somebody, looking at their warning signs and being aware of those warning signs, and to know like when this comes up, who do I talk to? How do I start to connect with all these other resources I have? That can be helpful to have a very explicit conversation with someone. Now, I put the safety planning in the order that was in the guides that I had, but I have down here number 6, making the environment safe. For me personally, that's once we're kind of getting to that place of someone kind of agreeing to kind of explore and look at next options, making the environment safe is really kind of the first thing, which is, what is your plan? Do you have suicidal ideation? You're thinking about it? Do you have a plan? Plans are really important, because if I have a plan, I'm more likely to do something, no matter what it is. If I don't have a plan, then that really reduces the imminent risk, but we still want to make sure, like, you don't have a plan, but do you have things around your house? Do you have medications? Do you have weapons? Again, with the way we have, like, the proliferation of weapons and guns in our communities, we were thinking all the time about mass shootings and stuff. Absolutely a real concern. But a lot of ways, like, all the guns in our communities get used is around suicide, actually. So if we actually had some measures of gun control, don't get too political here, but that would not only help for some of these mass shootings we're worried about, but also for suicide. People get a hold of them when they're in distress. It's on the means matter aspect of this, which is, we're talking about suicide intervention, like kind of what's wrong, what's going on, how can we help you? But we also have to start looking at how people die by suicide, and thinking about the access people have to lethal means, because you can make a decision pretty quick without having conversations with people and then be really at risk. So to help people, even if they're just having these conversations, like, you have guns around, if someone can hold your guns, is there a way, can guns be put away? I mean, this is a very complex discussion in some ways, but trying to find ways to make sure that there's ways of disabling the plan. Also, with this idea of helping to assess, like, what are someone's internal coping strategies and their external resources. So you really want to be able to go, like, when you start to have these warning signs, what kinds of things can you rely on inside yourself that's useful? Many of you are already working with people. I do a lot of DBT interventions and treatment, so I'm using tons of, like, distress tolerance and emotional regulation skills, mindfulness skills for people to practice and help when they're having some warning signs. But also social contacts. This is hard right now because there's not a lot people can do necessarily, but even in the age of being on screens, who can you Zoom with, who can distract, what kinds of things do you have as a resource there? Family, friends, and professional resources. And one of the things I encourage people to do right now is, in your safety planning, in addition to finding a plan that's, like, useful for you, that works for your agency is start to do some active partnering. So if you're thinking about like, what are the professional agencies in my community that I might rely on to help refer somebody, to provide support for someone, you know, to make these connections. Can I start making calls? Can I start researching online, especially now? Like, what's their capacity right now? How are they seeing people? How are they helping people? Are they essential workers? Do they have essential workers? Like, how do I start putting things in place just in case I need these resources? I want to be able to have access to them. Next slide. Okay. Another thing that we want to think about too is, you know, as we're building protective factors and safety plans, is, you know, we're often thinking about like all the things we want to put in there to make sure somebody doesn't harm themselves. But how can we also help build in, you know, scaffolding around someone? It's like, no, I'm not thinking about suicide, but, you know, we're not always so sure, like, might be different in a couple of days. And I have to say, that's one thing I've noticed in this pandemic among my clients as well as among myself, of all the kind of ups and downs that people go through. So I can work with someone who's feeling pretty stable or stable enough on Wednesday, and by Friday, they're pretty stressed again. So always thinking about where are the, you know, effective clinical care for mental, physical, and substance use disorders. Like, again, this idea of building those community connections. Thinking about what are some of the best practices for support and help, and also support for help seeking. What's our network of support here? What do I have out there that I know in terms of food resources, in terms of housing resources, and thinking about a lot of your clinical kind of case management, because that's something that can help protect people, especially now when we have folks losing things, when they haven't been accustomed to losing things. Do they have their ongoing medical care? Again, people are losing their health insurance. So how do we help make links to medical providers? And again, I'm not saying any of this is easy right now because there's a lot of pressure on the system, but it's good to be thinking about it ahead of time. Problem solving, conflict resolution, that could be skill sets that we're teaching people. I think that's very helpful right now because people are at home. They're getting triggered by each other. We also know there's an increase in interpersonal partner violence, domestic violence, things we need to be concerned about in that regard as well. And faith communities, how can we help people connect with faith communities right now? A lot of communities are online. I have many clients right now really taking advantage of their 12-step community. A 12-step did a great job going online. I gotta say, they did a great job, and it's not for everyone, but there are many people who are finding a lot of help with 12-step right now. And I can't say enough about how appreciative I've been and how it's been such a protective factor for a huge section of my caseload. Next slide. Okay, I think we're getting close here to the end. I want to have some time for questions. And so again, there's something about safety planning. So this idea of the way I'm presenting this and being motivational and conversational, and we're trying to guide people from being unsafe to safe, right? That's ultimately our idea. But sometimes with our best medicine, our best attempts, our, you know, wonderful skills, we still don't get there, you know, and at the end of a session, or someone hangs up on us, or someone takes, you know, we're really worried. Okay, we need to, you know, look at like, what do we do if we need to involuntarily hospitalize someone? We definitely, someone is at the place where they might need hospitalization. That might be part of the planning that we get to. And if we can have someone, especially if we can see the person with them, right? You know, family member come on screen and bring them there. If we could have them be there, or we have someone come and connect with them, that's great. But sometimes we can't. You know, sometimes we have to do welfare checks, and we have to go that route. You need to know the responders in your client's community, right? Which is why I'm in the place right now of making a bunch of lists for students, because we're seeing people maybe outside of our usual community. Also be sure to have like consultation options to review for challenging situations. You know, if you know people, again, I would be, you know, curious, kind of looking around just in your own network about, you know, who's working on crisis teams, who is often dealing with folks with, you know, kind of chronic conditions. I think knowing people, say like in substance use treatment programs, people who work maybe in like DBT teams, and they're often very good people to be able to develop in some sort of consultation, support team. You got to kind of figure out how to negotiate all of that. But also, I would check in with the American Association of Suicidology. They do have some of those types of processes in place. And again, if someone has been hospitalized, like how does follow-up work? Because we want to make sure that we have people be safe. We want to make sure that we link people back into settings that'll help them maintain their wellness, whatever wellness they can build afterwards. So the case management, the care management is really important after an event. And let's see where we're at next. I think we're getting close here. Well, next slide. Okay, we are at the event. So a couple of things is I have a number of references, and including the AAS, Centers for Disease Control, and again, this is safety planning guide that I put in here. And next slide, so these are 3 websites I wanted you to have, and thank you, Robin, for including these. I like to actually show these at the end of my webinars. So maybe I'll show, we show the first one. Would that be okay to show the Know the Signs? See if this works here. Okay, some of you may have seen this before. I love this website. Let me just say that right now. It's beautifully designed. And why I like it is that you see the first piece, Know the Signs. And if you click on it, it brings up all the warning signs. So if you're wondering, or if you're even if you're trying to educate maybe someone's family members, like it pulls this up. This is actually was created with some great funding through our Mental Health Services Act funding a few years ago. And then the next one, Find the Words. If you click on that, it pulls up like all these ways to start the conversation and to do that focusing, right? That asking questions, and it talks about just kind of general for teenagers. It talks about for older adults. Yeah, so these are some of the Know the Signs. You can see where you can kind of click on these and it gives you examples. It's a great design website. And the third one is like the resources. So that's where you get into the safety planning. And if you click on that one, it pulls up all the different counties in California and who some of the safety kind of safety teams are, and crisis response teams. So that's excellent to have. And then being aware of time. I know I'm really getting close on time here. I did put on here the National Suicide Prevention Hotline. It's the hotline. It's one number if you need to have like. You got that, you got that, but it also just has like a lot of great resources as well in terms of getting help and getting involved, providers and professionals, a lot of resources, and it has the 800 number. And then finally, because I adore it so much, I have the American Association of Suicidology, and again, you can find all evidence-based research. You can see what's going on in the field, tons of resources. And they are staying like so on top of like kind of current issues in suicide research, kind of social issues, how to involve family members, survivors. They've done just some really terrific work, especially around peer resources. So I'm just aware of time. Jennifer, should I stop right now for some questions?
Yeah, I think we've had a lot of questions coming in, and so I think I'm going to have time to ask 1 or 2. And then I did just want to let folks know that we do save all the questions. We send them to our presenters in order to be able to have them answer them when they are not totally finished with their not when they're sort of tired from their webinar. And then we post those to the website. So, KRISTIN, this one is actually sort of related to the website that you just showed. How can therapists best help someone who is suicidal due to racism and just a sense of hopelessness about really being able to change these systemic factors?
Yeah. So this is great. It's a great question, and it's like really up right now too. And I think it's this. So all of this, I mean, in some ways, it's like kind of keeping it simple. The more complex things get, it's this kind of my mantra, like the simple we need to be, just by being able to be reflective and listening and mirroring, and being curious of someone. This might be also just where kind of on those motivational interviewing skills too. Like once we've done some engagement, really exploring with the ask, offer, ask kind of piece about asking like, what do they think might be helpful? Even if they're feeling like really despairing, like what kinds of things are they seeing or they've been connected with that, even if they're not ready for it, like they might kind of imagine could be a useful kind of next step for them. Maybe offering some potential ideas for like, empowering ways of getting involved, but maybe on different levels, and then helping them kind of choose to kind of think about, if any of that seems like it would be relevant to them. And I just want to be really respectful of the fact too that, especially for, someone who's, the victim of racism, it's like, and this is, I think, what we're learning with this current movement, which I think is fantastic. It's like, it's not, racism is not theirs to solve. I mean, they have to learn how to respond in ways that are helpful, but really it's for people who are being, racist, people with the power and privilege. It's like, it's our job to be working on this and to be dismantling this. So, but within the kind of their context of like what they can control and what could help them, feel more empowered, helping them have that choice without feeling like, okay, let me shift more burden of like solving racism on you, right? I mean, because that's not what that's about. But it's just like in your world right now, what would be really helpful and empowering for you to be able to have maybe that conversation. And recognizing that's complex, and also just honoring the fact that they're willing to talk about it and they're feeling that despair. Again, the feeling of pain, like underneath that is like, the social justice and the equality is like really important to them. And it's important to them and for their families, and just to be honoring that.
Great. KRISTIN, thank you so much. As I said, there are a number of different questions. Those answers will get posted to the website, but thank you so much for your time. Really informative, lots of great feedback in the question box. I want to also thank the California Healthcare Foundation for sponsoring the webinar series, and really want to thank all of you for being able to attend today.